Dr. Garcia, welcome. That's my jam right there. It got a little
I love
like,
that. You guys did such a good job. You did such a good job with
uh.
that.
Anyway, hey, thank you everyone, and thanks for listening to Sports Doc Talk. Be sure to check us out on your favorite listening platforms. We're on Apple, we're on Spotify, iHeart, you name it. And now with our videos, please check out our YouTube page, Dr. Garcia. We're really excited about our guest, but before we bring on our guest, how are you? I know I was having some issues. I didn't know if we were going to get the show going today because I was having internet issues and I was scrambling, but I'm hoping that your day was a little bit better than mine.
I was scrambling, but not from internet issues. It was good, busy, as usual. But yeah, I'm excited we can do this show. I mean, we just put on one last week, but this is a really important guest, and I'm excited for people to share. And we have breaks coming up and everything, so I was hoping we could get this on, and I'm so excited to introduce this. As you guys know, I ranted for about 5 minutes introducing this show about a week ago. So hopefully anybody heard that. If not, you will hear the update today.
All
I
right.
don't know, Will, if you want to kick it off, and we'll go from there.
Yeah, let's bring on. Hey, he's in our green room. All right, we're gonna send somebody to go get him. No, it's not that complicated. Let's bring on Dr. Shaffer there. Dr. Shaffer, welcome.
Hey,
Thanks for
hey.
hanging out with us. Dr. I bothered Dr. Shaffer there, and I was like, "Are you still in the operating room? You got your scrubs going on?" But I love how he said, you got to be ready to stay ready. So, welcome to the show, Dr. Shaffer.
Thank you. Pleasure to be on. Really, it's a privilege.
Go ahead, Dr. Garcia.
Yeah, so I'm going to introduce Dr. Shaffer. This is Dr. Andre Shaffer. He's a spine surgeon actually in my group, which is awesome. And we actually know each other really well. We've been friends for way too long. We went to hospital surgery, special surgery together, and he had the privilege of taking care of some pretty amazing athletes as well while he was there with me. And we've got along working together in residency. He actually went to Cornell undergrad as well, so he's kind of a slacker. And then now you have him having triple fellowship training he did one in Harvard for trauma, two in Seattle. He did hip preservation, but really the big thing and one of his real passions, again, with some minimally invasive stuff coming out, was spine. And so he finished his spine fellowship. He's been in private practice for a little while, and now he's joined us, and we are so happy to have him. I can tell you right now that I have way too many partners coming up to me telling me how excited they are to have Dr. Shaffer as part of the group. And for me, it's near and dear because it's really been nice to have someone like that takes things by the reins. And he's doing so many cutting edge things in Seattle. I don't want to brag too much about you, Andre, because you have to speak at some point. But he was the first person in all of Washington State to perform endoscopic spine, and I think an endoscopic spine outpatient, especially with the new Arthrex system, which we know we like to talk about that. And it was no internal brace, Will, but he still did it with just a regular scope. So we're going to talk about this procedure. It's really important, near and dear to me as well. But enough of that. Let's talk about how Dr. Shaffer's doing.
Ooh, I got 3 kids. My wife's putting them to bed, so I'm happy to be up here talking about spine. A good time.
That is great. In fact, let's take a quick look at the beautiful family. I mean, your resume is legit. As Dr. Garcia, tongue in cheek over here, saying you're a slacker, but I mean, your journey has been a very interesting one. Can you just give us a brief look in, an insight into, how you went from firefighter to now just a renowned surgeon, just a little bit of that journey?
Yeah, absolutely. Yeah. So I was born and raised here in Seattle. I was a Seattle firefighter for 7 years. And it was really a colleague of mine who fell about 45, 50 feet while training that even got me to go to college. And so, went to the University of Washington. I'm a proud Husky. And while I was in college, I kind of found my footing academically and decided, maybe I should shoot for something a little bit more, sort of rigorous than just being a firefighter. Loved being a firefighter.
More rigorous than a firefighter. That's something that you don't always hear.
Yeah,
More rigorous than being just a firefighter. That's amazing.
Yeah. So, I went to, like I said, I went to undergrad, did well. And then, I got to go to Cornell. I applied and got in. And so then, it was sort of like the dog that caught the car, So I was
Mm.
like, oh, wow, I got into medical school. So I should probably go. So went to medical school at Cornell. And then me and Grant met first day of sub-Is actually in Seattle at University of Washington. And then we ended up matching at HSS together. And,
On the other side of the country.
and
So
sort of
it was,
history.
you can't make that up, dude. We literally worked together for a whole month in Seattle at University of Washington doing trauma, which, by the way, everybody knows I'm not a huge fan of that. I like sports. But nonetheless, I did it because I was interested in going to UW. And then we ended up together in New York, which was crazy because we didn't really know until we showed up. I
So we
saw
showed
your
up,
picture and I
oh,
was like,
hey.
dude, I know that guy.
Yeah. Yeah, it was a good time. So yeah. So now I'm here, and when I was in residency, I wasn't a lot of our spine was open. I was interested in spine, from biomechanics, and sort of it's important, right? Your spine connects your head to your torso, and so uh very important stuff, but just it was so open that I wasn't really as much of a fan of that. And the patients had a hard time kind of bouncing back from some of the bigger surgeries that we were doing.
Mm.
And so it wasn't until I was in my trauma fellowship and I'm seeing some of the work that people like Andrew Simpson was doing up at Harvard, big MIS proponent, and watching them do tubular micro decompressions and seeing like, oh wow, there's an alternative. And so that was what got me interested in spine. Um, and then when I was doing my hip preservation fellowship as well, seeing how much overlap there was between the hip and the spine and how many patients would come in with hip problems that we would send off for their spine and vice versa. And so, that kind of primed the pump. And then I went off and did trauma and hip for a while. And then, finally, when I started hearing about spine endoscopy or endoscopic spine surgery, that was the thing that kind of told me, hey man, I gotta go back. I gotta circle back and figure that out. And so I got to work with some really great neurosurgeons and orthopedic surgeons in my spine fellowship down in Phoenix, Arizona. And, they enabled me to kind of go to whatever classes and courses I wanted and kind of check stuff out. And, my program director was interested in endoscopy as well. And so we did, a handful of them and during the year. And then I kind of took that, that basis or that foundation and said, hey, let's run with it. So
This is a good segue. So Will's seen this. You saw this with Dr. Acevedo. You went from open spine surgeon to minimally invasive spine surgeon to, if patients don't know what this is, you are essentially scoping their spine.
Yeah.
And you took this to the next level because we talk about this in the surgeries I do. You see the surgery, you practice, and then you do it on a patient. I've seen where I know what you've done behind the scenes, obviously, because we chat about it all the time. But maybe tell the audience, like, how did you get to this level? Like, it's not everyone can say like this is like going from like making cereal to a filet mignon. Like, this is next level stuff. Like, you can't see anything that's going on until you put that scope in. So you're finding it localized. And this incision, this looks massive, but I'm an arthroscopist. So this is my wheelhouse in terms of these scopes. That incision on the screen is like this big. So tell the audience like what it takes to get to this level. So people need to know that, this is not something that just straight over simple, easy to do.
Yeah, no. So, I mean, you have to have a number of skills. And I think, this is where some of my other experience doing trauma, kind of comes in, because a lot of the first portion of your case is localization with an x-ray. And that's something that if you do trauma, you're really comfortable, steering needles, steering, dilators to a specific place using an x-ray and doing it safely, right?
Mm.
And so, the first thing is understanding the anatomy, understanding what you're trying to actually accomplish with your tools so that you can use an x-ray machine to get there safely. And so that's tricky, right? Because you have to find where you make your incision. You have to find the trajectory, and there's a lot of planning and work that goes into it. The patients, get onto the table, and I'm taking x-rays and measuring things and being really careful. And they almost look like a blueprint, because there's so many markings. But that's, because I'm trying to make sure that we make one incision, that we're being as minimally invasive, but also as safe as possible in the process. And so, you make an incision, you take x-rays that are, AP, lateral, which are different types of views. You take some oblique views, and you kind of combine them so that you get a sort of a three-dimensional representation of what you're looking at in your mind. And then it just, it's, sports, Grant, it's triangulation and just, kind of having the hands to say, this is the angle that I'm going to go for. And this is where it's at. And so what that took for me was, going to, cadaver courses, and then beyond that, practicing on cadavers and, practicing, in the lab a number of times so that we felt like we were ready for prime time. And so at this point, I've probably done 40, 50 levels in the lab, just making sure that I can, consistently target, that I can consistently get access to the foramen, or consistently get access to the interlaminar space so that we can be safe and effective.
And I think it's important for people to know, like, this is not a skill that's easy. I every day scope, right? I'm doing 5 scopes, 6 scopes, and you see residents that try to do it, or fellows as they start, and they struggle the triangulation. So Dr. Shaffer went from a spine surgeon. He had the hip arthroscopy skills. He has the skills he learned at HSS. He has this trauma skills, but he had to put all those together to do this. The result is a significant improvement for patients, but also it shows dedication, right? Like, there's a lot of people that don't want to do this. Not only is it challenging to get this product in a surgery center outpatient, which we will talk about in a minute, but on top of that, getting an outpatient and doing it safely and doing it well is no feat. It is very, very challenging. There's no joke here. And the fact that he's able to do it consistently is really impressive. And I think that I really want patients to know about this option, because we've seen it. And this is basically where sports was about probably 15 years ago. And I think that we're literally at the cusp. And I feel like Will and I could have this conversation with you in 2 years, and you'll be like, dude, I'm way beyond that. Like, we're already like on this trajectory. Yeah. And what do you think about endoscopy and spine surgery? And where do you think this is going?
I mean, I think it's at its infancy. It's been good. It's what's crazy is it's not new. It's been happening for 20 years, but it just hasn't gotten the acceptance, right, in the United States. People were doing it out in South Korea and Japan, but not as much in the United States. And so, I'm kind of happy to be one of the few people locally that are doing it, and being able to being able to do it in the ASC and get people home right away, right? I tend to call my patients, 2-3 days later, and I had a guy a couple weeks ago who I operated on. And I called him, on a Friday, and I hear all this commotion in the background, and I'm like, "Where are you?" And he's like, "I'm at work." I'm like, "Dude, you're 2 days post-op. What are you doing?"
You did his surgery on the Wednesday, so people need to hear this is 2 days later.
On Wednesday, I called him on Friday. And he's like, "I'm at work," and I was like, "Why?" And he's like, "I feel too good not to work." And I was like, "Are you taking it?" He's like, "I'm taking Tylenol." And so that's.
And what do you think this guy with an open discectomy? What do you think would have happened for him? Again, it's different, hard to tell per patient.
Yeah, no, he probably wouldn't have gone to work for 3 weeks or so, just because you have so much more soft tissue dissection with an open discectomy, right? And even a tubular discectomy, you're taking bone. There's more that you're doing, getting there just so that you can see the tissues. There's a lot more that you do, and so this is kind of one of the cool things is that you can make these really small incisions, and they're powerful because you can see so much more because of the magnification of the scope. And one of the other large benefits of this is that when you do this, because sort of the approach is so small, you have more muscle that's working appropriately right away. And the people who love that is patients for sure, but who else loves it is physical therapists, right? At the end of the day, they're the ones that are spending hours and hours and hours with these patients afterwards, trying to get them back into the game, trying to get them back to where they're going. So this is one of my favorite slides, right? orthopedic surgeons, we love what we do. We're pretty happy, but it's ultimately the physical therapist that kind of flushes that, dunks the ball, right? We pass it off to the PTs, and we do a great job. But what we do essentially is we fix anatomy, and then the physical therapists will sort of help rehab these patients, across the finish line. And so that's I think that's one of my big reasons for spine endoscopy and minimally invasive spine surgery in all is just taking sort of what spine used to be, which was this open, morbid, difficult recovery, and hearing these amazing patient stories where they're like, I have no pain, I didn't take any medications, I feel great. I mean, I think that to me is like one of the most satisfying things about it, and that's why I'm so passionate about it. Right? I get to scope the spine. It's great.
Dr. Shaffer,
And
I just wanted to kind of follow up there with, from the patient's point of view, when you say, and I've had friends have surgery, and we'll kind of, maybe we'll get into that in a second here. I'm going in for back surgery, and you go, oh shit, excuse
Yeah.
my language there for the youngins, but it's that stigma of, oh my, you're going in for back surgery. What does that entail? How debilitating it is. I had a friend, and this was probably about 12, 13 years ago, went in for major back surgery from the back and then cervical in the front, about 8 hours. Took him, he didn't feel right for almost a year. And to the point where he was like, I wish I didn't have surgery. In
Yeah.
about a year time, he started to feel better. It was like, okay, I'm finally better. I can walk. He's a chef. So standing up long hours, everything like that. But that stigma about back surgery, now with this new technology, instead of maybe being fearful, maybe we get excited because there's hope and relief for people that are suffering through this type of debilitating pain. And if anyone's had back issues, you can't walk, you can't sleep, you can't move. It is by far the worst.
Yeah. These patients with radiculopathy, you have a disc herniation, and you essentially get in through 8 millimeter incision, and you find it, you localize it, you find it, and you start pulling that disc out, and then you close. It takes 2 sutures to close. You glue the skin closed and put a little Band-Aid on.
A little Band-Aid.
A little Band-Aid, little tiny
I've
dressing.
seen it. I saw his patient. They literally this tiniest little.
And they go home and they're showering, and they're out of pain. Like you go see them in the recovery room after surgery, and they're moving their foot, and they're just looking at it like, this is amazing. It works. The pain's gone. And that's, I mean, it's just, and then,
Will, you can see that Dr. Schaefer's pretty low key, low enthusiasm for this procedure.
Yeah,
no, it's important. And obviously he made a mention at the beginning of the show that he was inspired from what he saw, that kind of, it's always wonderful when our paths go down a certain route, that especially if we're not expected, but to give people an option to be pain-free, you're giving quality of life, right? I've had piriformis flare up, and I'm like, I can't move. I'm picking up my leg to swing it over the bed, different issues at different times that's happened. And I can't imagine anything worse than that. Maybe I'll stick with that right there. Why is something like piriformis happen so frequently? Is that something that's just body, or over time, or stress from playing ball, or anything like that? Is there anything that you could pinpoint, or is it just a matter of time as you get older, maybe a little arthritis, just wear and tear? What's a normal cause? Because I know so many people suffer through piriformis or something similar like that.
You know what I think it is? So your nerves don't like being touched. Nerves in the human body is something that, Grant knows. If to find a nerve, you find fat, right? And that's because the body puts fat around nerves so that nerves don't get touched. And so if you are touching a nerve, it's going to irritate it. If you're touching a nerve in 2 places, it's going to irritate it even more. It's called double crush syndrome. Okay. And so you may have some tightness, you may have some spasm in your piriformis muscle. But I think what happens is as our backs start to degenerate a little bit, right? A little bit of degeneration, that's that second hit, right? That's the second place that nerve's being touched. And so, if you have a little bit of degeneration in one place and a little bit of, in the other place, it's not like they're adding, they're multiplying, right? Because nerves just, they don't take a joke. They don't like being touched at all. And so that's, I think, part of what it is, right? You push a nerve around a little bit too much, it'll let you know. And that's why it's so debilitating. That's why it's so painful for folks.
Yeah.
So I love the piriformis syndrome, but I want to go back to endoscopy. I love talking about it. So what makes this so difficult outpatient? Like, why are we not seeing this more frequently? Again, Dr. Shaffer, Proliance, first one, like, this is not easy. And I think there was a number of things that collided here, but maybe you could tell a little bit of a story, because I think that's important for the listeners to hear too. Doing your surgeries at hospitals sounds all great. The problem you have is you get hit with a massive bill. I know, I've had spine surgery at a hospital. I can show you how big the bill is. And I know surgeries at the surgery center and how much they cost too. So, there's differences just in that component. And then the other thing is finding a provider that even can do it. I mean, we see it all the time. I see it all the time. I didn't even know this was an option. No one told me about this. And Will and I talked about this. How do you find innovative people? And so what is a journey that you did briefly to get to this level? You're doing now things outpatient, endoscopy, and still no one's figured out how to do it yet.
Yeah. So when I was, like I said, this is the reason I went back to do a spine fellowship, right? I was practicing, I was happy doing, trauma and hip stuff. But saw this technology and said, hey, I gotta get on with this. This is something I gotta do. And so right from the start, when I was in my fellowship, I was, talking to companies about, hey, like, how do we get, how can I do this, after I finish this fellowship? And, they all want you to buy a very expensive tower, and they want you to buy very expensive equipment. And, the outlay is $250,000 at least, right? Just to get it. And so, that was kind of a thought, like, all right, well, build a practice, and, slowly but surely we'll get the equipment. But one of the cool things about our surgery centers, we have essentially, half of the equipment that you would have to buy already, because it's used for arthroscopy, right? And so if you're part of a big hospital, if they don't have, a certain tower, like an Arthrex tower, if they have a different company tower, they're not gonna buy a tower just for you to do spine endoscopy, or very few will. And so it can be difficult just to get the equipment, just to get the basic equipment in. And so, I kind of got on the ground floor with a company, Arthrex, that's, really trying to revolutionize spine endoscopy. They're doing a lot of development work, and they're, taking off. And so I got in really early with them, and, got to go to one of their first labs. And I've been, going to a lot of lab time. Like I said, probably 40, 50 levels at this point. And, helping develop, tooling and evaluating things and things like that. So that, we know what we can use, so we know what's safe, so we know what's efficacious. So there's that. So I think the cost is one aspect of it. I think, a lot of the spine surgeons who are out there, I think are good surgeons and are very capable surgeons, but this is essentially arthroscopy. This is a different skill set. It's a different way of looking at something. When you try to do, an open ACL, which I know no one does that anymore, right? Especially not.
I'm gonna shake on the camera a little bit.
Not in Grant Garcia's neighborhood, right? But when you go from open to trying to do it through, a small incision with, that's and instruments that are 15 centimeters away from where the pathology is, that's difficult. That's a different set of hand skills. And so, I had the benefit of doing, 150 hip scopes in fellowship, and doing, knee scopes and percutaneous access for some of these, for some of the nails and other, intramedullary things that I did as part of trauma. And so I had the benefit. It's not like I'm the greatest thing since sliced bread. It's just I had the benefit of being able to have some of these skills already from different equipment, right? And so if you have those skills and you're saying, hey, I want to do something smaller, well, there it is right there for you, right? And if you have those skills, then it's not going to be, 4-hour ordeal to take a disc out, right? It's going to be.
And I think that's also a big thing, right? I mean, you had a lot of pushback before you came, not from me, but in general from everybody, because, before the Arthrex system came out, it was a very expensive. The cost, Will probably heard that cost. That's pretty high, even for medical facilities. And so you basically have a complete barrier. We talked about this before, Will, right? This is a perfect example of tech and blocking, right? No one pays for that equipment except for the surgeons, and then it gets reimbursed over time and pays itself back. But going in the black that much is usually not a really good benefit. And it's hard to get everybody on board when, open discs do fine, but they're not great. And so as a result, it's hard to really convert. And that's one of the reasons. And the other thing is the skill set. And the other thing is like taking a long time. Like if Dr. Shaffer starts doing these, and instead of it taking 1 hour, it's taking 4 hours, and patients are doing worse, that's another problem too. So Will, we've talked about this, like the surgeries that I do for some of my crazy surgeries are more MEMS. We're still efficient. And if we're not, that's when problems happen. So when people dabble, and I always tell people, if you're seeing somebody, you don't want a dabbler, right? Yeah. It's okay if people are a little slower. There's not about different timing and, being 10 minutes faster. Like you don't want to time yourself in the OR and things like that. That's not appropriate. But if you are proficient, you should be efficient in the operating room. And efficient in the operating room is actually important. And some of the best surgeons are the most efficient. It doesn't mean they're the fastest, because there's not the fastest. I'm saying it's efficiency. I told Will before, it's like like you're in an orchestra, right? You're doing it. But the fact that, Dr. Shaffer's first endoscopy was like an hour and 15 minutes, and it was a really tough case. And your second one was like an hour or something like that. I mean, we're talking about, this is not much added time, and all those benefits we see there. And honestly, the drawbacks are really, that's again, just those are standard risks. And I think we've talked about all the different things, but I don't think most of those will, eventually kind of go away, right? I mean, most of those things are minimal.
I think it's, I think a lot of it is, like the operative time. It depends again, it depends on the pathology, depends on the patient. And honestly, I think a lot of it is your surgeon's comfort level, right? With the equipment and with the technique. So, my first one took I think it was an hour and 45. I don't think it was an hour 15. I think it was an hour and 45 minutes, but it was a really difficult case, and then my next one was an hour. It was just under an hour, and so it's there is a learning curve there, but I think it's a pretty steep one. I think it's pretty rapid in terms of the progress that you can make, especially if you have some, other skills that are applicable to what you're doing.
Well, I think also Will sees now, we talked about this many times, Will, with all the other surgeons you've had on, practice a little more, think about it, get better. And so that's, for the viewers, that's the most important thing in your surgeon, in my opinion. And Will probably, I don't know if Will agrees with this, but like, the mentality of like, getting better each time, right? What did I do? What do I need to make notes on? What do I need to do better? Like until you got it. And then once you got it, don't get complacent, right? 6 months later,
keep getting better.
Going.
Keep getting better.
Keep getting better.
Right?
Because it's better for the patient
also, right? Access that certain doctors have compared to others, right? Whether if they're working at a hospital, what equipment is available to them. So there's a lot of levels to all of this, just from the prior discussions that we've had with folks, where maybe they're not privy to some of this stuff, right? And that's why we always tell the patient, please go get a second opinion, right? And obviously with insurance, that can make things pretty complicated, and so we start to go down a slippery slope here with a lot of the discussions, right? So, whether it's, do you have the option to have a fusion or a disc replacement? Maybe you don't have it. Why would insurance then say, well, you're better off to have a disc replacement, but we're going to approve the fusion, where I'm not sure what the percentages are, but you may have to reoperate on those. So it's a I guess a gray area, and you guys would know better than I would. Yeah. But just from listening to the conversations, there's a back and forth dance that kind of happens between patient, the doctor, and insurance. So that's always an interesting dilemma.
Well, Will, you had to go there. Now it's time. We can
Sorry,
talk about disc
my
replacements, which
bad.
is as
Sorry, insurance
exciting.
company.
It's okay. No, I love it. So this is
Yeah.
important. This is why I wanted Dr. Shaffer on here, because this stuff is really new as well. And
Yeah.
so I want him to talk about, I think let's start with the one that's more common, which is the cervical disc replacement.
Absolutely.
And kind of tell about the differences in that and really why it's better for younger patients and what's the benefit. And then let's talk about lumbar, because lumbar to me is valuable, but I also have a personal interest in this. So, this to me at first, obviously cervical. So, tell us what's a cervical disc replacement, and we'll maybe throw up the slide there so people can see. And then, there you go.
So one of the ways that you can help patients. So generally, when you're doing surgery in someone's neck, it's for nerve compression. Okay. And it's for nerve compression from a disc that's herniated, that's squeezed out the back and pushing on the nerves, right? Like we said earlier, nerves don't like being touched by anything, including pieces of your own body. So one of the most powerful ways of getting that compression off is by taking that disc out from the front generally, which, believe it or not, is easier for patients and is less invasive than going from the back. But going through the front, finding the disc and pulling it off, decompressing the nerves. And once you've done that, you have a space that's open. And that can be, that's a lumbar disc replacement there.
We'll go back to the cervical one.
But yeah, once you get that space open, you have to put a spacer in there to sort of hold the bones apart and keep all of the anatomy in the right place that it's supposed to be in. You can do that one of two ways. You can do that with a fusion and with a static spacer that doesn't move, or you can do that with one of these, disc arthroplasties that you see here. And what those do is those have end plates and a little core that allows the end plates to move and flex and bend.
So that's more natural, right?
Much more natural. You don't lose as much motion. And what we're finding is, there's a risk of something called adjacent segment degeneration, right?
Well, this is what you were talking about.
Where when you have one segment that's fused, all of the patients still move, right? Just because you fuse one level doesn't mean your neck is going to be rigid. You're going to move. You're just going to put more stress on the other discs while you're doing that. If you're young, that means you have a longer lifetime of more stress being put on the discs. Also, you think about your 30-year-old patient, your 35-year-old patient, they're doing more intense things, right? They're doing CrossFit, they're running marathons, they're doing things, they're really using their neck or their spine, as opposed to maybe it's a little fewer and farther between to see a 65-year-old, doing workout of the days, right? And so younger patients put a lot more stress on their neck. And if they have a level that moves, that's a lot better for them. Ultimately, because there's a lower risk of adjacent segment degeneration. But there's also better outcomes. Patient reported outcomes are far superior with a disc arthroplasty. My brother had a disc herniation, and I made sure he got a disc arthroplasty as opposed to a fusion because he's younger than me. He's in his 30s, and so it's really important to I think to preserve motion in the spine as much as you can. And so I'm maybe a hair less passionate about cervical disc arthroplasty and lumbar disc arthroplasty than I am about endoscopy, right? I like endoscopy, but I love disc arthroplasty as well. There are some times when you shouldn't use a disc arthroplasty, and a lot of that is based on how much arthritis you have in your facet joints, and those are the joints in the back of your spine behind your spinal cord. And so some people disc arthroplasties still aren't a good option in. But
how does arthritis affect that? Just so we can have a better understanding. If you have arthritis build up back there, why wouldn't you want to do something like that?
So if you have arthritis in your neck, in the facet joints in the back, they still move when you have a disc arthroplasty. So you can still have residual pain in the back of your neck. It may be something that you can tolerate. And so that's why it's always a conversation with your physician
Yeah.
right? We always talk about what the goals are, but it may be something that you need that if neck pain is a big part of what's going on, as opposed to arm pain, then sometimes you say, yeah, well, maybe we should do a fusion, but generally most patients, especially younger patients, do a lot better with disc arthroplasties as opposed to fusions.
So your
And
evaluation, I'm sorry, your evaluation then it goes across multiple levels, right? The age, what's happening to them physically, what needs to be done, maybe if they have an arthritis. So
Yeah,
you're taking all of this, wealth of information and then coming up with what's the best course to treat this particular ex patient moving
absolutely.
forward for what's happening now and maybe how it affects them in the future.
What do occupation?
Mm.
Are you hypermobile? Are you, what do you do things where you need overhead, where you need to be able to do things overhead? Absolutely. I mean,
Picking up 3 kids at
yeah,
home.
right. Exactly.
yeah,
We will put different disc types into different patients based on
Mm.
how their body is, right. Some discs move less, they're more constrained. Other discs are less constrained, and if you have a patient who's hypermobile, you're going to put a more constrained disc in generally.
well, that's interesting to hear. You'll first off to comment, Will, you heard about the dreaded back surgery, right? Well,
Oh
one of
yeah.
the other things people worry about is with back surgery, you get recurrence. Like a lot of these back surgeons, patients are for life, right? Every
Mm-hmm.
5 years you come back and get your next level fused. So the idea behind, I think, this is not only is it not it's a one-time surgery, or lasts a lot longer, and you're having less issues above and beyond. So the goal is, I think, long term, right? Would you say this, Andre, that you just have the patients are not coming back all the time, right?
Yeah.
The goal is to reduce the number of long-term surgeries for these patients, because a lifer of spine is never a good outcome,
So
for at least for
there's
what I've seen and Will's seen.
there's a number of reasons I think that disc arthroplasty is the future of spine surgery, right? One, you get better patient outcomes. Two, less need for operations. They're supposed to be. I was just seeing something the other day that says there's supposed to be a 1,500, 1,200 spine surgeon shortage in the next like 10, 15 years. And if I've got patients who keep coming back because they need fusions, that's so many patients that don't get care, right. And the longer you delay spine care, it tends to constrain your options to things like fusions, right. You need patients who've ignored their neck, ignored their back for 20 years, and it's harder, right. So I always tell people, hey, make sure you're doing your physical therapy exercises, and I say, hey, but if you're having issues, don't ignore them. Come back. The sooner you come to see me, the sooner that I can do something small, as opposed to having to do something big, and if I can do something
Mm.
small and get you kind of back on the way, that's so much better than if I have to do, big multi-level fusion. I'll do them if I have to. I'll do them through MIS techniques so that we get people back up and moving quickly, more quickly. But my preference is to do something small that, preserves motion and, has people, extremely happy right away. And that's it. That's because that's what I ultimately want to do.
And I think for this is important, Will, we have said it before, this is why second opinions are so valuable. Even today I saw 6 second opinions, and 3 of them had heard opinions that were completely different than what I told them. Right. And you're getting an opinion saying you need to have a fusion of your neck and you're below 60 years old or 65 years old. And you're like, it's only been bothering me for a little while. That's someone you should maybe think about it, because sometimes if there's not a lot of arthritis, the fusion sometimes is the easier option, right? It's easier to get approved by insurance. It's
Yeah.
cheaper
But
for the surgery, but it's not the right answer. It sure as heck is not the right answer. So you got to make sure, if you're a patient, you really go to the people. If the person does, I tell someone, if they tell you cervical arthroplasty or they tell you something doesn't work, they better be the one that also does those surgeries. Because
Yeah.
when someone says it doesn't work, the number of people I've seen that have said some of my surgeries don't work because they never seen them before. I'm like, that's not very helpful. Like you want someone with experience that has all options. And so
right.
that's why it's great to have someone like you on here to talk to the patients, to hear about this, especially the younger patients who want to get back to sports. They want to get back to things.
So
You don't want your neck fused.
So one of the things that's interesting, Grant, is that disc arthroplasty is actually cheaper.
Mm.
Disc arthroplasty is actually cheaper than when you start adding up all of the
The fusions,
components.
right?
than fusions. Yeah, fusions.
Yeah.
There's I hate to say it, there can be a financial motive, that exists for people saying fusion.
Is the fusion something that I'm not trying to throw insurances out the bus, but is this something that they kind of defer to? Is kind of like you go to the doctors and they say, well, we're going to take an x-ray first. And you go, I don't have a broken bone. Like, I know I need an MRI. Well, we got to go through the x-ray first. Is that just part of the process when it comes to something like this in your field, when it says, well, we're going to explore this route first before we go to the next?
I think the reason that insurance companies like to steer patients away from arthroplasty is because arthroplasty doesn't have the same volumes, and so there aren't the same discounts on implants. Now that said, the amount of implant that you put in is generally greater, right? So if I do a disc arthroplasty, that's the one implant that I put in, right? So that's the one implant that your insurance company pays for. But if I do a fusion, I'm putting a static spacer in, I'm putting a biologic in, I'm putting a plate and screws in, right? There's a lot more that goes into it. And again, sometimes a fusion is the right thing. It's not, again, I don't want to come off as dogmatic and say it has to be an arthroplasty, because I tell plenty of patients, and I do plenty of fusions, but if I can avoid it, I like to, right? If it's safe to do it, if it looks like it's going to work for the patient, then for me, I'm looking to do a fusion, I'm looking to do an arthroplasty as my default, and I have to have a reason to not do the arthroplasty.
Your first option.
That's 100%.
Yeah.
Listen, everybody hear that. We're going to repeat that on the next thing. That is the number one thing you need to hear in your surgeon. What is your default?
Yeah.
Okay. You're a spine restoration surgeon, basically, at this standpoint.
Right.
And when people, it's the same thing with mine. You come into my office, the default is to save your knee. The secondary, tertiary, or fourth option is to do a knee replacement. Right. Or do a shoulder replacement.
Right.
So this is what I'm talking about. This is really important. I think Will would appreciate this. The best outcome for the patient is to save as much as possible of the person's body.
Keep your parts.
And if that's not the default, then you should be concerned. Yeah. Okay. Now, again, you say the default is that, but that doesn't mean you can't jump. Right. I don't want to get too sidetracked. I want to jump to the lumbar spine, because that even though these seem like they're the same, they're not. And for insurance authorizations and getting approved, and we've heard about the roadblocks, the lumbar spine, would you agree, has more roadblocks than the cervical spine?
Absolutely. I think insurance companies are more reticent to approve lumbar disc arthroplasties than they are, lumbar fusions. And I think it's probably one of the more unfortunate things that's kind of happening right now. This is actually an investigational device that's having some pretty good, kind of reports initially. They're going through their ID. They're already enrolled. But this is most lumbar disc arthroplasties you have to put in from the front. So you have to have an incision on the front of your abdomen. You have to have a vascular surgeon, move some of the structures so we can get access to that, to the spine, and then we have to take the disc out and put the arthroplasty in that way. But this is actually something that you can put in from the back. And what's really cool about it is you can put it in through minimally invasive incisions and with minimally invasive approaches, so that you're not devitalizing a lot of the muscles alongside the spinous processes. And I think that's one of the reasons, to get back to that, we talk about adjacent segment degeneration and people taking such a long time to bounce back from spine surgery. I think it's because of the traditional approaches, where it's a big incision and you essentially, make a midline approach and you just reflect or move a bunch of muscle off of the bone. Well, when you do that, that muscle doesn't work the same way. And if you ever have to come back and look at that muscle, it's scar afterwards. Versus if you can do it through a minimally invasive approach, where you're going through a small incision and you're spreading muscle as opposed to stripping muscle, that ends up with patients who, have dramatically less pain. That's I think one of the reasons why endoscopy is so powerful, is because you're spreading muscle, you're not stripping muscle. The other reason is the fluid, whenever you're washing away all that inflammatory, sort of the inflammatory chemicals that happen as a result of surgery, you just have less inflammation post-operatively. But to get back to disc arthroplasty, that Modus is I think that's going to be a game changer when it comes out and gets approved.
And again, we like new tech. So this is important for patients. This is a young person's surgery, right? You don't fuse their back, you give them this replacement. And the nice thing is if you can do it through the back, you don't have to stay over house, right? Usually those patients, that could potentially be someone that goes home. And potentially a surgery that's done at the surgery center for outpatient purposes. Is that correct?
Yep.
Versus when you get it from the front, you're going to the hospital for that.
Yeah.
And that's more challenging, and you're already fighting with insurances. And as soon as you get a hospital stay and insurance doesn't want to cover it and you have to pay out of pocket, you're looking at a 5-7 times cost to the patient, right? Because it doesn't go to anybody but the patient when it's not covered, which stinks. Right. So I think this is really important for patients. I think the one last part we're gonna get close.
Uh-oh.
Looks like we lost him, but we'll just kind of keep that going as he comes back. I saw today on Good Morning America something that they had determined at the Mayo Clinic, and let's bring Dr. Garcia back. It's okay. I'll just finish my thought, and then we'll get you back in there, Dr. Garcia. Saw it on Good Morning America today. They had done a paralysis stem cell study at the Mayo Clinic. They had 10 patients, 7 of them had really great results. 3 didn't have bad results, but pretty much stayed as is. So my question to you is the role that something like stem cells will play a part in surgery, back surgery going forward, especially with something like this that, they were talking about this just today on Good Morning America.
Yeah, I think I'm a big believer in stem cells, but I'm measured about their use in the back, especially right now. You have to know why something works in order to use it appropriately and have patients get good benefit from it, I think.
Mm-hmm.
And, are there patients that get benefit from stem cell injections into their back? Well, it depends on what the cells are, right? Are they, and it depends on who the patients are, right? Are these young patients? Are these old patients? How bad is their back?
Paralysis. I mean, that was the study. So it really bad, right? I mean, they're pretty much dire
it's
here.
Probably the lowest.
They can't move.
But that's probably their nerves, right? I think a lot of patients come and ask me about, disc herniations and, well, can I just put stem cells into it?
Okay.
You can put stem cells into it, but if your disc is already degenerated to the point that it's not, that the mechanical environment isn't going to let the stem cells make cartilage or make type 1 and type 2 collagen, then it probably isn't necessarily going to work. And so you got to be, I think you got to be careful. I think in 20 years, we're going to be a lot closer to that kind of holy grail of, saying, hey, you have a problem with your disc and we're going to do an injection of stem cells into the disc.
Abdominal fat out of you and put it in your lumbar.
Dude,
right. Yeah.
I'm telling you, Dr. Shaffer's coming back on in a year or two. We're going to hear about the Modus spine happening all the time. We're going to hear about him scoping everything in the back, the front, who knows? And then we get to hear about biologics and spine.
Yeah, I wanted to bring it up because I'm pretty sure that people will approach you about that without having the information, the knowledge. So I think it's important to at least discuss it. So it's great. Thank you for talking about that.
And obviously, interest of time, but I do got to ask this question: do you ever do, or is there ever a reason to ever consider doing PRP in the back? Like, I know people get it done. As a guy that does a lot of PRP in the knee and occasionally the shoulder, I get a lot of patients asking about it for the lumbar spine or for the cervical spine. Is there any data that's out there, or what's the top?
Yeah, no, I mean, I think it's actually, so there's data that says it's as effective as an epidural steroid injection.
So would you consider doing that? Like, let's say someone failed, like, you have 1 epidural, 2 epidurals, and they're just okay. Would you ever say someone's like, dude, I don't want my disc done? Would you say, hey, listen, they're like, I want to do a PRP.
Yeah.
Would you consider that? Is that some time where you would kind of think about it?
Absolutely.
Okay.
Yeah. And so the interesting thing about the disc injections is that, or spine injections, is that epidurals are helpful diagnostically for us as well as therapeutically for patients. And so, I want to see that you're getting some improvement from the epidural injection, at least temporary, right? Now, if it doesn't work, I can always do another one. And if that, works, but doesn't really get it done, if you don't have anything that's compressing on nerves, then I'm inclined to say, hey, yeah, let's do some PRP at that point, right?
Okay.
And that's I think the stem cells, right? That I think are that we kind of have a good sense of, okay, it may work for us, right? As opposed to some of the, taking fat out of somebody's thigh and saying, oh, you got a little lipo and you got a little disc injection,
You got
I
a
mean,
2-for-1.
look at Dr. Shaffer. He's a plastic surgeon and spine surgeon, all mixed in one.
I wish. No, but yeah, I think it's I think PRP is something that's a little bit different, right? There's a lot of data behind PRP that shows that it's effective and shows that it's safe.
Awesome.
And now there's data that's showing that it's essentially got similar efficacy to the to epidural steroid injections. And so I'd consider it for a disc that's really bad, but not that bad, right? I might consider it for a desiccated disc as opposed to a completely degenerated disc.
Awesome.
All right,
Will,
before
so
we
I
wrap
think
it
we're
up,
running
I
down.
just wanted to just show this here. I didn't show it to Dr. Shaffer, and if you're listening on a podcast, check us out on our YouTube page so you can see the slides and see our beautiful faces. So please check us out. We always talk about patient relationships and how important it is, and I just wanted to share a few things from the patients. Just recently from the last month or so. If you go to patient reviews, please check it out. I'm just going to highlight a couple of things. He fielded all my issues fully in a manner that made sense to me, even if he probably felt like he was drawing a crayon, just making it really visually and just breaking it down so they can understand. Dr. Shaffer exceeds far beyond standard care. It's another review. I appreciate that he starts with the least invasive treatments and continues from there, depending on results. And by the way, I had this all set up before we even talked about it. So that is a great way to just showcase what we've done. When you have this feedback from patients, when they walk out of your office and they're happy with not only the treatment, but the doctor-patient relationship leading up to the treatment and post, what does that mean for you as someone that does this, in their profession, but that helps so many?
Yeah, I mean, it's doing what we do is a gift. It's an honor, right? It's a privilege to be able to help people in the way that we do, right? You think about, how privileged you are to be able to help somebody get back to their life. And so, that's what I want, right? I want people to understand what their options are. I want people to feel comfortable with the options. I want people to feel comfortable with which options they're choosing. And then I want them to feel like, the experience is as least traumatic as it can, right? Because if you think about how scary it is to go to a doctor's office and how scary it is to have them talk about, procedures and surgery and things like that, that's not really an enjoyable, it's just not enjoyable, right? And so I don't really want to be somebody who's just sort of, slogging through patients and you take it or leave it. That's just not really, that's not my personality. And so I want people to feel like they're, like they play a meaningful role in their care, because they do play a meaningful role in their care, right? I think if people are happy, that they're gonna do better. If they feel like they got the best shot at, getting what they wanted and it helps, they're gonna do better. And that's all that's what matters, is people doing, people having excellent outcomes, through, minimally invasive, means, and, helping them out.
So I think that's important for the listeners to hear. You've heard Dr. Shaffer talk, you've seen his innovative stuff, but also the personality is important. And I find that when people come and they get extra opinions, again, another reason, just get another opinion, because sometimes you got to gel with the surgeon. I mean, like Dr. Shaffer can mention this, but if a patient doesn't feel comfortable with you, I don't want him doing surgery with me. Right.
No.
I want it to be, everyone's got to be comfortable. As soon as I had a patient today that was terrified of the other surgeon, and she wants to go to him because she knows the person. And I'm like, that's the silliest thing I've ever heard in my whole life.
Yeah,
I was like, you should feel if you're afraid of the person that's operating on you, or you're nervous about it or something, unless you absolutely have something that's the only person in the world, which is pretty much never the case.
Yeah.
Get another opinion. See someone that you like, that you know, and that's why we do these videos. You know, this podcast for someone like Dr. Shaffer, so people can meet him and understand that. You know, we just talked for an hour. That was pretty easy, and we talked about some pretty intense stuff. And so you're in there, you're nervous, you're getting your first back surgery. Just reach out. So you know, you've got this is a good option for patients. And then think, if you don't feel comfortable about the situation, there's something you think there's something else you're missing. That gut feeling you have inside when you meet somebody and you're like, I think there's more to this. I think it can be done differently. There's got to be another way. Just look it up on your own and find the right person for it. But I think it's really important. I think Will know this. Back surgery is terrifying, especially big stuff. And sometimes it might not be necessary, or the key is just to get the right stuff. Right, Will?
100%. Dr. Shaffer, thank you so much for being our guest and just sharing that wealth of knowledge and just kind of hanging with us.
Yeah.
We'd like to thank all of our listeners and viewers. Check us out at sportsdoctalk.com. And we're on Sports Doc Talk Podcast and on YouTube and iHeart and Spotify. Dr. Garcia, stop me. I'm going to keep rambling.
You keep going. I'm listening. And check us out our website, www.sportsdoctalk.com. You can see everything. You'll see transcripts of the show. You'll see video podcasts. You'll see split video podcasts. And on all the social media we'll be posting. And you're going to be seeing Dr. Shaffer's beautiful face pop up a few times in the next month or so. So check it out. I'm excited to show you guys off and show this stuff off. Patients need to know about this. This is not common surgery in the Washington State area. You need to hear this. Consider it. Think about it. I can't tell you guys anymore. I've done my best. Okay. That's it. There's no more I can do.
All right, Dr. Shaffer, go back to being dad now out of 80 roles that you have. Thank you so much for hanging with us. Take care.
Thanks for having me. Take care, guys.
Bye.